Narcan will work on any opioid. So if it binds to the opioid receptor, Narcan will work on it. The thing is that we have multiple opioid receptors, right? So there's some opioids that bind to different receptors. Narcan has the strongest intrinsic activity, which means the strongest binding capacity to the mu opioid receptor, right? But if you have the kappa or the gamma, and I can't think of the other one. If you have an opioid binding to that, it will take the naloxone longer to attach, and it may take more of it.
Don't Hide the Scars, a weekly podcast focused on addiction and recovery. Created by the nonprofit PAIN, Parents and Addicts in Need, and founded by Flindt Andersen.
Look at that handsome face right there,
He's
Flindt.
back. He's back.
Narcan Nate, what's going on, bro?
Hey, what's up? How you doing?
We're hanging in there, and we appreciate you coming on because, we've, I don't know if you caught it, we've kind of ventured down a series of different topics, and you would help bring something up. We want to get more clarification for the listener on Narcan, what it is effective on, what it isn't, and what you're seeing. So, because what was it? Carfentanil we were discussing,
right?
Whether or not it is or isn't effective.
Yeah. So it's effective. I mean, I think a lot of the scenario is that people don't respond properly. I've even seen first responders that they just dose, especially if it's like law enforcement, they just dose and wait. You have to supplement oxygen, because if someone's suffering respiratory depression, which is what an overdose is, that means the blood is not flowing as it would. So the blood flows and it carries the medication to the blood to brain barrier, which the medication then crosses over and then goes to the receptor. So if you're supplementing oxygen, one, you're hopefully preventing hypoxic brain injury, and two, you're helping the blood flow to get medication faster to the receptor. Yep. But most people don't do that.
Right. So basically what they're doing, they're just taking the 4 milligrams, giving them one dose, waiting and seeing if they're going to respond. And that wait time could be anywhere from 30 seconds to 4 minutes. I don't know on the latter part of it. But I'm assuming that a lot of these people are probably not dosing fast enough, because you can continue to dose and it's not going to hurt anybody.
Well, yeah, the only thing with dosing is that if they're opioid dependent, you could put them in withdrawal, and
that's true.
And they may not go to the hospital, and they may miss an opportunity to get access to treatment, whatever that may look like. And they also, it's what's known as rebound killing. So you put someone that's opioid dependent into precipitated withdrawal, which can be gnarly.
Right.
They might just get up and run and go smoke or shoot again to try to get well again. They might die because they're alone. No one sees them.
Yeah. And I think some of that happened early on, in particular early on when Narcan really came on the scene, because I know a couple people that happened to. Mm-hmm. So again, like we want to do today, we just want to get the real facts. We want to get, exactly, what is the right time frame to get that dose in somebody, and then I do want to talk about a little bit on some of the methods that are coming about, like the 12 milligram Clodaxo. Has that literally hit the market yet, or is it still just out there floating around somewhere? Those kinds of things, Nate.
Oh yeah, for sure, absolutely.
So again, look, I was also reading today on nitazene and that drug. And they are saying that Narcan is not effective on that, at least from the articles that I read this morning. But again, every body is different. Every body is gonna respond differently, I think. So again, is it better to start off if you think somebody has taken tranq, that we just start out and give them 8 milligrams to start right off the bat, and wait that another 30 seconds or a minute, and then give them the third dose?
Well, here's the thing. The data. So if you talk to the people at Cloxado, they don't have any data to back their claims up. It's all, anecdotal, and like the qualitative and quantitative data on this is very subjective, because if people aren't rescue breathing or supplementing oxygen, or they're just dosing like within 30 seconds, that's not accurate, because you're supposed to dose, wait 2 to 3 minutes, and while you're waiting, you supplement oxygen.
Yeah.
The recommended dose, when you use intermuscular naloxone, the recommended dose is 0.4 milligrams intermuscular. When you use you also get 100% of the medication that way. When you use intranasal, you get, it has 50% bioavailability, right? So there's actually no real justification for higher milligram opioid antagonists. It's basically just marketing and capitalism off of fear and inaccurate information, and people just trying to get into the market while they can get in because it's profitable.
Yeah.
So, but I mean, I had to save someone on Monday, and we dosed him, and then his girlfriend would just slammed another dose in his nose, and it wasn't even like 30 seconds. I was like, you didn't have to do, like, the dude was starting to like come back like shortly after that, and that's not always the case, but I just haven't seen the data that shows that, and any subject matter expert that I've talked to says, and anybody that like works in like community-based outreach will tell you that they've never seen the need for it.
Yeah. I mean, I remember when actually the Cladaxo people called me one time, and I did a little investigating, but I was kind of gun shy right at the beginning to even, kind of talk to them and commit to the fact that we even wanted to try it. I love your answer on that, as far as the marketing piece of this and getting into it just to make some more money. I also think, that look, this is just me, man, but I also think we might be sending the wrong message, when we start coming up with, 12 milligram, naloxone, 16 milligram, 20 milligram, 24. I mean, how high does it have to go? Because we know there's stronger opioids coming on the market. I mean, there's so much different bullshit going on with this that, again, we just want to get it right. We want to get it straight. So, that we can tell our people this is exactly what you need to do. But you brought up something that I need to ask about. So you talk about, supplying the oxygen as well. What happens? Mm-hmm. What happens when you are, a family at home and their kid's not using, but some other kid comes over, he goes into overdose. They happen to have Narcan. Look, response times for paramedics. I was one. Okay. So, and of course that was 150 years ago, but in those days, I mean, our response time, I think, was about 12 minutes anywhere in Fresno. But now that it's grown and we're up to over 1 million people, and, you got traffic and trains and bullshit going on, I'm sure those response times can be somewhere, around 14, 15, 16 minutes.
Yeah, I think the average, and this could have changed. The last time I looked at it, the average response time was like eight-ish minutes in an urban setting. But that's, that is subjective as well, because there could be all sorts of things that could happen, like you said, traffic, inclement weather, everything. Right. You know what I mean? And yeah, so I mean, it's definitely crucial that you get it in there as soon as you can.
Mm-hmm. Okay.
And so when we talk about the circulation of oxygen, are we talking compressions?
I don't teach compressions, because if they have a pulse, there's no need for it. You're gonna potentially break their ribs and cause more harm for no reason.
Right.
And while pumping, you could be just giving oxygen to them. So because a lot of people aren't comfortable with giving mouth to mouth, which is why I always give out rescue breathing masks. But I just let people have autonomy. If you're not comfortable, do chest compressions, like whatever, just something to get them to do something that'll supplement oxygen.
Got it.
Okay. Yeah. Thank you for the clarification.
Mm-hmm.
So what, as far as like Flindt brought up, trank, we were talking, carfentanil. What from your knowledge is or isn't effective on? Obviously with trank, I mean, with the nitazene in there, that it's not an opioid, so it's Narcan's not going to do anything, but I would think it would still help in some regard.
So Narcan will work on any opioid. So if it binds to the opioid receptor, Narcan will work on it. The thing is that we have multiple opioid receptors, right? So there's some opioids that bind to different receptors. Narcan has the strongest intrinsic activity, which means the strongest binding capacity to the mu opioid receptor, right? But if you have the kappa or the gamma, and I can't think of the other one. If you have an opioid binding to that, it will take the naloxone longer to attach, and it may take more of it, which is where I think some of this information is coming from. But with trank dope, so trank or xylazine is used to give fentanyl legs, right? It's like taking an oxy and a Xanax. So the high lasts longer, right? Because fentanyl is a short-acting opioid, right? So if someone overdoses on trank, it will still reverse the fentanyl overdose, and you're more than likely to overdose on fent before you will trank. Trank just makes the overdose more complicated to treat because it closes the airways, so to speak. It's almost like wooden chest syndrome, to my knowledge.
Mm-hmm. Right. Yeah, because it's an animal tranquilizer, right?
Yeah. So but it can be used for surgeries. They can use it on cats as an emetic, but yeah, it's a tranquilizer.
Yeah, and it hasn't been approved for human consumption, but it is for animals,
Yeah.
Mm-hmm.
What about with croc?
Croc, I've never been asked that question. I know crocodile it's pretty much synthetic desomorphine. I don't know that I've ever read any information on what a crocodile overdose looks like, but I mean, it's an opioid, so you could use Narcan on it.
Okay.
Well, early on with crocodile, in essence, what they were doing now, maybe it has changed to some degree because I haven't really kept up on crocodile too much. But early on, it was actually found along the Russia-Armenian border, and they were using the old Tylenol number 3s with codeine, and they were taking those pills. They were buying them for a penny a piece. They were crushing those up and actually mixing gasoline in with the Tylenol number 3s, and that was giving them that heroin type of high. Now that was early on, so if they've changed that mixture of whatever, I don't know, but that was originally crocodile when it first came out.
Yeah, I know that the wounds that appear from it is part of like it's just a bad cook, so to speak. So when they synthesize it, it's a byproduct that causes those wounds with it. That's what it is.
Right. Right. Yeah, and those wounds, man. I mean, wow, those things are. That's some of the worst crap I've ever seen, to be honest with you.
Yeah, it's pretty bad. Yeah, those wounds are bad. They really are. Which I don't even know that I've heard anything about crocodile in years now.
Yeah, I remember once though. There was a few reported cases. I want to say like up in the New Hampshire area. Yeah, and I want to say that was maybe 3 years ago, 4 years ago, and then nothing. And then absolutely nothing.
Yeah, it didn't make it on the market. Yeah.
Right.
Yeah. Little too complex, more complex, maybe. I don't know.
Who knows?
New Perceptions North, the premier drug and alcohol treatment and recovery center in Central California. A full continuum of medically supervised, top-quality care with programs for detox, inpatient residential treatment with dual diagnosis, intensive outpatient treatment, sober living, support groups, and more. With 50-plus years of combined experience and sobriety, Flindt, Andersen, and Thelma Gatlin Wilson provide adult men and women with the highest caliber of professional health care, treating each client with compassion and respect, and a safe, comfortable environment. To begin the process of recovery, to proudly create and sustain a life without addiction, call 559-978-1507 or visit newperceptionsnorth.com.
Nate, well, you're in San Diego still, right?
Yeah, I'm still in San Diego.
Yeah. Are you starting to see more of these situations coming with where it's evident that someone's using trank over just fentanyl?
No, as far as we know, trank's not even made it here yet. It's not been detected. They've seized it at the border, you know what I mean? But that doesn't mean that shipment was going to San Diego.
Right.
Still no way to know that. But I know San Diego's the biggest port of entry for substances in this country. So God only knows where it was going.
Right. Yeah. Well, a lot of it's going into San Francisco for sure. That's a fact. We've seen some of it up here. but nothing like San Francisco. I mean, just it's all over the place up there.
Yeah. I heard it was up there.
Mm-hmm.
What about in Seattle too? Right? Isn't it hitting pretty good in Seattle?
I believe it's hitting Seattle. I believe it's in Portland. Not well. Again, we've heard about it in Los Angeles, but nothing like it's been reported in San Francisco.
Yeah.
It's like it's just invaded the city.
Yeah, well, I mean, it's taken over in some of these cities. It's taken upwards of 60% of the supply in like 6 months.
Yeah, that's major, man.
That's alarming.
Yeah, no one's prepared for it.
Right,
No.
right. Well, and again, that's what you just said is a very, very important statement. Nobody's prepared for it. So, like what we were talking about earlier, I've seen, since the mid '90s, I have seen this thing just come to full cycle here. We saw that in the '80s and '90s. Regular opioid use and doctor shopping and those kinds of things. And we've seen that increase. Then here comes OxyContin. We saw what OxyContin does to everybody during the 90s and the early 2000s. And every 5 to 10 years, it just seems to grow. And then the stronger drugs come into play. And the stronger ones, a lot of these drugs, like I was telling Jason today, were developed back in the 40s and 50s. And my only explanation is they've kind of been sitting dormant, but somebody's going to find out where these are and what they are. And they're going to continue to produce these stronger medications because our quote addicts and substance users in the United States, we're going to require more and more potency in the drugs we use. And we have learned nothing, Nate. It seems to me we've learned nothing about this since the 70s and early 80s.
Yeah. I mean, typically we see a supply shift every 4 to 5 years. And I mean, Trank was in Puerto Rico in the early 2000s, you know what I mean? And they even reported that it was in LA, but they didn't, I guess the police department didn't want to work with public health or something happened like that. And then it's been in Kensington for like 5 years, you know what I mean? And so they say, it just floors me when they say it's an emerging threat. But the only thing that's emerging is our public health response to it.
Right.
And it takes 4 to 5 years for us to get a game plan together. You know what I mean? That was just something they did at the ONDCP to like have a good news statement because they had their or whatever,
Mm-hmm.
But yeah, it's something else.
No. Go ahead.
No. Go.
I was
go
just
ahead,
gonna say, it's baffling in how to. I mean, you go through it. You're out there. You're boots to the ground, which I'm grateful for you and to know you. But what's it going to take for it to become an actual like response? Flindt and I were talking, Nate, on one of the previous episodes where we just did kind of like a coffee talk, as we were calling it. And you'll see protesting over tons of things, which I'm not taking validity, but we're losing, we're expecting maybe 100,000 people in 2022, and we're headed there in 2023, at least for sure. And nobody's marching, nobody's protesting, nobody, there just doesn't seem to be the same kind of outrage when we're losing this many of our citizens.
Yeah, I mean, I know some people have been going to the Capitol. I know some people that have been going to Sacramento. Well, here in California, Sacramento, and then Washington. I think the problem is that everybody thinks their idea of what it's going to take. Everybody thinks they're right, and I think a lot of people don't want to compromise. And I think a lot of people aren't willing to let go of whatever they think might work. And I think we got to completely just change our approach to it. We couldn't treat everybody right now if they wanted treatment, if they wanted it. You know what I mean?
Right.
We could not do it. And we've got to, we definitely have to stop and see what we're doing. I mean, the DEA just got $43 billion in funding, and that's not going to touch anything. You know what I mean? Like, right. I mean, they'll get procedures and stuff, and all that stuff, but that's not going to touch it. I mean, I think funding is one thing, because I mean, if those people if 97% of the potentially 40 million diagnosable substance use disorders in this country, if 97% of them perceive that they don't need treatment, that tells me we need to invest money in harm reduction or any pathway to mitigate harms for those individuals. That's what that tells me, but we won't do that.
Well, look, look, I am one of those guys in Sacramento. I am one of those guys that sit in the committee hearings for health and public safety. I am one of those guys that sit in front of these assemblymen and listen to the bullshit that spews out of their mouth. And I was up there 2 weeks ago. And let me tell you something. I have never come across individuals that I wanted to somehow take down. And I'm going to say that publicly, because these people are fucking idiots. They sat there, Nate. One of them specifically sat there, and I quote, and this guy's his last name is Zuber. He is from he represents Santa Monica. He's assemblyman. He sat there and he had this look on his face, and he goes, I cannot believe that drug dealers are lacing every pill with fentanyl. This guy doesn't even have a clue, or he's acting like he doesn't have a clue. Another assemblywoman by the last name of Bonta looked directly at my administrative assistant, who told her story about losing her son, and said, Miss Smith, I grieve with you, but is it really going to do any good to put that person in prison? Let me tell you something, Nate. There was a young lady sitting next to me who works for our assemblyman's office, and she's patting me on the knee going, calm down, because the stupidity of these people that are sitting up in Sacramento, here's what they don't have a clue on what's going on, not a clue. They don't understand addiction. They don't understand the addict. They're asking the wrong questions, and they're asking the wrong people the wrong questions. Because if you look at our system, it basically comes down to two different types of treatment. And I'm just going to call a spade a spade. It comes down to the people that have insurance and PPOs and the right kind of insurance, and it comes down to the people that have Medi-Cal or no insurance. Period. I own a treatment center. That's what it comes down to, right? Okay, so let's take it a step further. The insurance companies from the private treatment side of this thing, because like I said, I do own one. Their job, when somebody comes into our treatment facility, we have to fill out what's called a utilization review to tell the insurance company why we need to give them X amount of days of detox. It's and with the doctor sitting on the other side of the bench with the insurance companies, their job is to come back and say, we're only going to give you 3 days of detox for this person. Now, on the second day that person's in treatment, we have to write another utilization review telling the insurance company and asking them for 3 more days, because this is where the client is. And he or she is not ready to be released into residential or outpatient. That little cat and mouse game goes on the entire time the person is with us. And the insurance companies are cutting, the majority of them are cutting those down to 17 days in treatment. And we all know it takes a hell of a lot more than 17 days to get anything accomplished. When somebody's in treatment for 17 days, you know what? And you have to release them afterwards because the insurance company isn't going to pay for it anymore. We're just telling them, hey, go back. You might as well just go back out and use. Because less than 1% are going to make it out of there. Less than 1%. Now, and we did it today, and Jason can attest to that. To attest to this. There was an article in USA Today, and they gave a telephone number, an 800 number after the article was written. And again, it was on Trank. That was one of the ones I was reading. Here's an 800 number for call for treatment. I called it. That phone number, after going through 2.5 minutes of a voice message, told me to plug in the first 5 letters of my city. We did that. That immediately directed us to the Fresno County Behavioral Health that gives an 800 number for treatment. And in the middle of the day came on another voice that went another 3 minutes on here's your options to call. That is with every county-run program in America. You've got that addict or that substance user on the other end of the phone, they're already off the phone. They're already off the phone, especially if somebody's going through withdrawals. They need an answer, and they need it now. And if we can't somehow get these people to understand, oh, by the way, there was not one thing in those messages that stated anything about inpatient treatment. Nope. It had it about outpatient. It had about children's services, adult services, this service, that service. Nothing about let us refer you somewhere. And here's another side to it. I know I'm rambling a little bit here, but this is important stuff. Let me tell you something. Again, and you hate to break this down into a socioeconomic group, but the reality is just that. Most parents that are of some sort of means, and I'm not meaning, again, you have the ultra rich, you have the middle class, but they have means. They're not going to send their kid or their loved one the first time, second time, or third time to a county-run program. They're not going to do it. This is what I've done for 15 years. These are the people that I've dealt with. They may send them to a county-run facility on the 5th time because they're tired and they're done and they're out of money and they're out of insurance. But that first or second time, it does not happen because those county-run facilities are they're messy inside. They're dirty inside. They're an absolute joke. By the way, most counties in this country will not even take a patient or a client in on a Friday, Saturday, or Sunday. Their phones they stop answering the phones on a Thursday night. If we can't, if the government programs, why aren't they working with us? I'm more than happy to be able to even reduce prices somewhere to get somebody in if we have to, or somehow look, as a business, we have to be able to stay profitable so we can keep our doors open. Not every treatment center is making millions of dollars and screwing the insurance companies. We certainly aren't doing it. But if we can't stay profitable, and especially in the state of California, my God, what our costs are, I half the week I got a pit in my stomach. And until we can somehow form something to make this accessible and affordable for the person and somewhat profitable for the treatment centers. And like you said earlier, if 90% of these people wanted help right now, we couldn't give it to them. I'm getting madder by the minute at our state legislator. I'm getting madder at the minute with insurance companies. It's like there are plenty of people that out there using that want the help. Now there's some that don't. There's some that's just going to keep on using, but there's a lot of them out there that want the help. I saw a YouTube video yesterday that somebody sent me on a young man named Blake. And I sent it to Jason, and it was done down in Los Angeles. And Blake is actually from Fresno. He's living in the tents down in Los Angeles. This is an ex-baseball player from a local high school here who was an absolute stud. This guy was, while he's doing the interview, he's high on fentanyl. He has to be. I understand that. I'm a recovering opiate addict. I get it. He passes out during the interview. He comes back on, he tells his story, and this is what stuck with me most. He goes, I really do want the help, but I got nowhere to go. And there's nothing I can do to even help the kid. I just don't get it. with our state and what they're thinking, because they don't understand any of it. They've been told the same thing over and over again by people that don't even understand addiction. There, I got it out. I mean, God, there's so many of us sitting here that want to help these people. And okay, let's say they come in, we get them some help, and they go back out and use again. All right, but let me tell you something. If we could turn this system around, and if we could keep somebody for a minimum of 90 days, if we could keep them up to 6 months, let me tell you something. I do believe that those recovery rates will rise, because now we've given them a reasonable chance. Instead of just getting the drug out of their system, kicking them to the street, their brains aren't ready for it. Their maturity isn't ready for it. It takes, Jesus, we all know it takes 9 months for some of the cravings to go away.
Mm-hmm.
But until we do that, we're going to be in this same fucking mess.
Yeah, I agree. I agree with you. Yeah, I mean,
I had to go off, Nate. I've been holding that in all day.
No, it's true. It's a pretty horrible feeling when you're done and you want help, but it's easier to score than it is to get into treatment.
Yeah.
You know what I mean? Like, I've been there, and that's a horrible feeling, because like, if you felt hopeless before you tried getting into treatment, while trying to get into treatment, that's when you really feel hopeless. And it's like, you might as well just keep using it. You know what I mean? Because and I get it. Yeah. There's, it's so hard to get into treatment, and then the battle with I mean, honestly, the people that write utilizations, like, the worse off you go in, the better off you are. I mean, I remember the last time I went to inpatient, inpatient. I think I got like 20 days, at that, and then they gave me the boot. That's nothing. You know what I mean? And they saved the rest of my time for like IOP,
right.
And it's like I understand, like, the for-profit, it's a business in the model, but these insurance companies are absolutely ridiculous. Like I know there's good and bad treatment centers, you know what I mean? That's a whole nother rabbit hole right there, but they make it impossible to treat people. Like, They literally make it impossible, and they put you or the providers in a very shitty position, because you have to do what you have to do, but because if you try to save everybody, you would go under. You wouldn't be able to help anybody. But they put you as being the bad guy, and we should be able to treat people reasonably. It shouldn't just be about their bottom line or them trying to, you know what I mean? Because not every treatment center is shady and trying to milk money out of the insurance provider.
That's right.
But on the other hand, the state could do more about that, because there could be better regulations over that.
Yes, I agree wholeheartedly with you on that.
Because that would make it easier for the good guys like you that are actually trying to provide ethical treatment, instead of trying to body broker or give kickbacks for getting a naltrexone implant or, whatever. It would make your life a lot easier.
You bet it would. You bet it would. I mean, that is one of the biggest struggles with those of us that are doing this the right way.
If you or a loved one is struggling with addiction, please call Parents and Addicts in Need at 559-579-1551 or check us out online at painnonprofit.org. Follow us on social media at Pain Nonprofit. Please subscribe to the podcast and share with others wherever you get podcasts and on YouTube. To donate, please click the link in the description and help us save more lives gripped by addiction.
Dealing with the state is hard enough. I mean, dealing with the state of California, just because I own a treatment center, my God, I think they just stay up late at night thinking about all this shit that they can put on us. Because half the time it's look, we've got us that are on the upper end that are dealing with those people, and our staff takes care of the clients, right? They don't have to do both. But you've got some private treatment centers that are really good, right? Really good, but maybe they've got a staff of, I don't know, 5 or 6 people. they really can't do their jobs very well, and they're not going to be around long, because of all the regulations, with the state. So it's we're kind of damned if we do and damned if we don't.
Yeah. Yeah, that's exactly where it is. Yeah, you're right. Yeah, you're honestly right. Absolutely.
End us on a high note.
And
Somebody end us on a high note. I got nothing.
Well, look, Nate, how long you been in recovery now?
Oh, I've been in and out of the room since 2015. Right now, I've got like 6 months, almost 6 months, I think.
That's fantastic, man. That's fantastic. Yeah, keep it up, brother. I mean, keep it up. I love what you're doing. San Diego. I've got friends that live down there, and we know this is a huge problem down there as well. And if we don't have people like you that are out doing this stuff, man, can you imagine what the death tolls would be?
Oh, it would be. Yeah, I mean, people that do what we do, like community-based distribution of Naloxone, we account for 59% of the opioid overdose reversals in the state of California. So think about that. Yeah, that's
cool.
That's insane. That's insane.
Right.
So yeah, there'd be a lot of dead people and a lot of grieving families.
You bet. So let me ask you this question too. So you guys go out, right? And somebody's been in an overdose, and you guys bring them out of it. What is your next steps with that person?
Well, if we call 911, and they come here, and I'm sure you have them up there, but I always like to mention taking them to a hospital that has a bridge program, right? To where they can go in, get access to some sort of treatment. If that doesn't happen, I mean, I know where places are where they can get referrals or how they can get in. I know of a few detoxes where they just take alcohol patients, but I do this and I'll be honest about it. If they really want to go, I'll get them lit on alcohol and take them and drop them off. So they'll blow hot and go into just an alcohol only detox. And I'm like, look, you tell them this, and this, you might be hurting, but this is the best I can do right now. But there's a few places where they can get resources, and I can take them there. And I think now they're working on this. The county of San Diego is working on where like certain people can, like if you want to get on OUD medication, they can do it for you. Go pick up the medication, bring it to you. Like they're working on things like that, to where you work with the doctor in the pharmacy, and it's kind of like this. It's like doctor, pharmacy, community outreach worker thing, like kind of like this triangle of care. So I know that's what's going on.
Do you guys have any treatment down there that does outpatient Suboxone detoxes?
Outpatient. I don't know. I feel like there is some places that do that. I feel like I've heard that before down here. I couldn't tell you their names, but I feel like someone's put that in my ear.
Okay, because my treatment center, we're actually licensed for that in the state to do it here in Fresno County. We can detox people on an outpatient basis with Suboxone. We can only do it with opiates. We can't detox alcoholics, with Valium or whatever it is, on an outpatient basis. But I'm asking you that for a reason, because afterwards I'm going to get your email. I think Jason's got it. I want to send you some information on some resources, even up here. Okay. That we could possibly help with. Okay. Because again, we take people 24 hours a day, 7 days a week, man. It doesn't matter what time. We'll even pay for them to come up. So, we can, yeah, perfect.
Yeah, even gone and you've gone and picked them up.
I'll go anywhere to pick them up, man. I mean, but anyway, it's you might want to check on that down there, to see if there's any place that does that, because there's not a lot of treatment centers that are licensed to do that, by the way.
Yeah,
because I don't even think they've thought about it, to be honest with you. But it can be done, and you can get licensed through the state on that one.
Yeah, I've seen honestly what I see most treatment centers doing, and I understand this. I just see them following the money because it's been so hard for them to stay open. A lot of them that they're just going to like following the money. Like a lot of them that didn't want to do like Suboxone or Sublocade, now they're doing Suboxone and Sublocade because it's just it keeps the doors open.
Right.
You know what they're doing.
Yeah, what we do is, I mean, obviously we have our medical director and our doctor that handles everybody's detox. But normally, what we'll do on the detox with opiates is it's going to be about a 10-day Suboxone detox off of opiates, and we start tapering them down almost immediately. But again, once you reach that level of you're done with that, it's so important for us to be able to keep them there, because now you're dealing with, once you reach that level, now you're dealing with all the psychological parts of this stuff. How do I live without either my drug or the Suboxone, the medication that helped me? I mean, it's a mess at that point. And that's why we fight these insurance companies to keep people in residential for a little bit longer, so we can at least get them somewhat grounded before, we've got to cut them loose.
Yeah. No, I think when I came off of Suboxone, that they tapered me with Subutex. And I think I got and I'd been on it for like a year and a half, and I'd been on Klonopins too. So, I mean, I was really going through it. I think they gave me my insurance gave me a 7-day detox, and they put me straight into IOP, which was part of the treatment center. But I mean, I was hearing stuff. I was hearing crazy shit. I wasn't sleeping. I didn't sleep for like 20 something days. I was seeing shit. I was like, dude, I shouldn't be.
Right? I mean, that's what I'm saying. Nobody's asking the right people the right questions.
Yeah. I thought every smoke detector had a camera in it.
And we can laugh because we've all been there.
Yeah. Over. I was just coming down. I wasn't sleeping. I was paranoid and all that shit. It was horrible.
It's horrible. It is horrible.
I literally saw Super Mario Brothers running through the fucking house with mushrooms. All right.
Yeah. Exactly. Well, Nate, hey man, thanks. You know what? It's a pleasure seeing you again. Yeah, keep up the good work, man. And like I said, I'm going to get in touch with you probably by tomorrow. Okay. And I'm gonna give you some resources and stuff. All right.
Yeah, that would be great. I greatly appreciate that. Thank you so much.
You got it, buddy.
Yeah. Thanks for your time and knowledge. Appreciate you.
Yeah, absolutely. Thank you as well.
If you or a loved one is struggling with addiction, please call Parents and Addicts in Need at 559-579-1551 or check us out online at painnonprofit.org. Follow us on social media at Pain Nonprofit. Please subscribe to the podcast and share with others wherever you get podcasts and on YouTube. To donate, please click the link in the description and help us save more lives gripped by addiction.